some reason that. Okay. So hello everyone. As Sarah said, I lead on staff support at the Evelina London Children's Hospital and for Women's Services, and I also have a senior role across GSTT, Guy's and St Thomas's Trust, and I'm a psychologist, and I've been in post pre-pandemic to do work in staff support. So I'm going to be talking today about why supporting staff is just as important as caring for patients. So I'm going to start with looking at why we need to support staff in healthcare settings. We'll be looking at some trauma and conflict contexts which explain more about why we need to support staff. Then I'm going to introduce the debrief pathway, which was first set up in the Evelina, and then we're in the process of rolling it out across our organisation. And then I've got some suggestions as what people might be able to do with limited resource in their organisations. Okay, so why do we need to support staff? Well, it's absolutely the right thing to do, and I was really pleased to see this in the NHS Constitution from January last year. It's felt that it's been the right thing to do by many of us who've been working for some time in staff health and wellbeing. What's important to bear in mind, though, is that while there is a need to support staff psychologically and in general well-being terms, I would always work from the assumption that staff are competent and they have some resilience, both at an individual team and perhaps broader level, because they're already working in healthcare. So it's not necessarily providing staff support because of a lack of resilience or because of a lack of competence or where there's mental health. Staff support doesn't always involve mental health, and we'll come to that a bit later. But we know that staff wellbeing affects sickness rates and retention. And we also know from all the recent and ongoing investigations that staff wellbeing impacts on patient care. So we also know that issues with well-being of staff have predated the pandemic. Healthcare workers report the highest rates of work-related stress, sickness absence, depression, and anxiety. So there is some mental health involved. We also know that there's been a rise in health inequalities across society, and obviously healthcare staff and staff in other organisations are part of that group, because we too have health conditions, or we have loved ones, or we care for people with health inequalities. We also know that ethnically marginalised staff in healthcare are more likely to face discrimination, bullying, complaints, and have to go through disciplinaries and have less opportunities for career progression. So this is a group of our staff that actually are more likely to suffer poor well-being as a result of this. And so we need to bear all of this in mind. Another kind of important context, some more important context really that can lead to stress and trauma and conflict as well is, I'm primarily going to talk about this related to pediatrics, but it is, we can think about this across the lifespan. But certainly these were contexts that help, that I guess we responded to many years ago when Sarah and I first started working together, as she outlined, that we were noticing were around, and that led to sort of an enhanced kind of staff support response. So for the last sort of 10 to 15 years or more, particularly in children. Due to technological advancement, we're seeing increased survival of children who might have previously died, who have complex health problems. And while this is obviously something to be celebrated in most cases, some of those actually are really technologically dependent and may have had a really rocky journey from birth through to discharge home and then back again into hospital. And so we're seeing a rise in these kinds of long stay patients that need a lot of input, and this can be challenging for the patients, for the families, and also has an impact on staff. And in some rare cases, it can lead to those kind of moral and ethical dilemmas about what are we doing here, and why are we doing this? And again, in some cases, it can lead to litigation, and some of the high-profile cases, one of them is illustrated in the pictures there, where the Pope and Trump became involved. And this had an obvious impact on staff, and obviously is incredibly challenging for all involved. Additionally, we know that more and more people reach for Dr. Google, us included. If we've got a niggle, or if we've recently been to the doctor, we might look something up on Google. And you know, in many ways, this is great for the public and for everyone to have more access to information. But obviously, the information that's out there isn't always correct, and it can lead to a rise in different kinds of expectations, and some of those expectations may not be realistic. So there, you know, there's a picture there which is wonderful, and we should be pleased about this, of a brain tumor girl who couldn't see or walk, and now she's doing cartwheels. But sadly, this isn't always the case in healthcare. And obviously, the impact of social media can really polarize and lead to misinformation as well, polarize narratives and lead to misinformation. Combined with all of this, there has been a long-standing lack of funding into healthcare in this country, as we all know, which pre-pandemic there was already staff and resource shortage. So all of this impacts on staff well-being, and with the pandemic and the fallout from that and subsequent recovery, we're faced with additional stresses and potential for trauma for staff. So what can we do about it? So we know that social support is one of the biggest predictor of coping with traumatic events, and there's long-standing and evidence to support this, and this has been replicated many times since. Gillian Colville is a psychologist who's worked in intensive care for many years, working with doing research into patients, recovery, families, and also in staff. And debriefs, talking with senior colleagues, and hobbies outside of work have all been found to be protective of staff well-being. Interestingly, things that are more preventative and proactive, such as supervision and reflective practice that are offered in an ongoing way, have been shown to improve effectiveness of care and to improve job satisfaction and reduce burnout. And our Trust staff wellbeing offer and the Evelina offer was based on this evidence, to sort of focus on peer support and focus on what staff are already doing to cope. So moving to that now, this is our, or this was our model for staff support that we developed before the pandemic. And a group of us, so Sarah, myself and a few other people from different disciplines met as a working group regularly over quite a long period of time, about a couple of years, and worked to pull together all the things that we knew were happening already in our hospital and to plug the gaps. So if we look at that triangle, and the top bit that you may not be able to read says universal culture of support. So it's important that what we were offering was fitting with our values within a universal culture of support as part of being a caring organisation, which stands for anti-stigma and discrimination. So from the base of the triangle, we pulled together some of the proactive things such as reflective practice and some of the training and things that were being offered on induction. Moving up the triangle, we can see where there's more targeted responses, such as case discussions facilitated by psychologists, or those interventions by the medical mediation team where they carry out mediation between staff and families, or between staff. Also, I've included in there something that staff psychologists are calling pre-briefs, which kind of are between reflective practice and debriefs, and they are usually used, they're a group meeting, they're usually used where there is either a long stay patient where there might be challenges and issues, there might be conflict or the potential for conflict, or there might be other kinds of complexities involved. Say there might be a court case going on for other reasons, perhaps linked to safeguarding, but where there's a long stay patient and ongoing challenges. Or it might also be used in the context of a patient that's well known to a staff team who is expected to die. And while this is incredibly tragic in itself, the management of it may be also causing some distress to staff. So in a pre-brief meeting, I'd say the two main things that you're addressing is clarifying the medical plan and communication around that, and also you're allowing a space for staff to explore the impact of the case on them. And then at the pinnacle of the triangle is the most reactive to events, which is our debrief pathway, which I'll go into more detail now about. So this is just it summarized. So it's a three-part pathway. It starts off with an immediate huddle, which I'm going to detail in a second. And then following that immediate huddle, you would have a check-in within 48 hours of the event. And between the first two stages, a decision is made as to whether a psychological debrief is needed. So immediate huddles, or hot debriefs, do not involve psychologists. That's important to say, and they happen fairly soon after an event. And the main purpose is to bring staff together following a potentially traumatizing event. And those sort of events can include things like crash calls, resuscitations, deaths, potentially a conflict episode, or any event that could be distressing or challenging. Another main purpose is just to check in with staff's emotional well-being, and you're not to go into any sensory detail around this, and to establish who's involved so you can provide follow-up, and to signpost and address basic self-care. And it's important to state that they don't replace any of the usual processes or meetings, such as patient safety or other investigations. So I thought it would be useful just to highlight running immediate huddles and some of the components that we would suggest you include. And this is something that we're rolling out, immediate huddle training in our trust across all our hospital sites and community. So In the first instance, you invite everybody who is involved to meet. Ideally, if it's been a crash call, you wouldn't do it in the same place, but sometimes needs must. Attendance is not compulsory. That's really important. You should also consider offering support outside of an immediate huddle to anybody who may have witnessed this event. You also need to decide who will lead the huddle. It's useful for a senior person to do so, and it's useful if someone who does it hasn't been leading the resuscitation or been key to the event, but sometimes sometimes people do have to do both. One of the main things that I think is useful to do is to get the list of names of people involved so that follow-up can be given. In holding the event, or in holding the immediate huddle, you're not to go around the group. It's not like a debrief following sim training, or people's contributions need to be voluntary. And immediate huddles or hot debriefs can take just 5 minutes, but sometimes teams might decide to go for longer. So you're to briefly describe the events and address any burning issues or questions that may be causing staff distress, such as, oh, did I do this? Did I cause harm to the patient? And where you can, then you try and answer those things. Focus on what went well, and then clarifying roles and responsibilities going forward. Another key thing to think about when you run hot debriefs is if there's any documentation that needs completing. Do staff need some support around this? So they may be really experienced and feel actually okay with the event itself, but may be worrying more about filling out documentation. And as I've mentioned previously, you then consider the next steps, such as the check-in or whether a psychology-led debrief is needed. So just to think about what you might be able to do if you've got limited staff support resource. So not everything needs to be done by psychologists. It's really useful to apply psychological thinking to how you offer interventions. It's key to, if you are offering wellbeing interventions, that you have lists of contacts for should a staff member or a team need additional support. So you need to have mental health contacts or be aware of the occupational health in your organization's contacts. I think it's also really important to stress that most of what I've talked about so far is about individual or team interventions, be it training or be it groups like pre-briefs or immediate huddles. But actually the most important thing to get right in an organization and that impacts the highest on staff wellbeing is obviously working conditions and also how organizations communicate. So you can be applying psychological thinking to this and also getting working conditions right where possible. And you can also make use of pre-existing support structures to bring in wellbeing conversations or team connection and social support. Lastly, of course, a little plug for the book. This covers all sorts of different ways of offering staff support in organizations, and while it is mainly focused on those who deliver staff support, be they psychologists or other mental health practitioners or wellbeing practitioners. It is also a useful tool for leaders or other people that are interested and involved in staff wellbeing. I thought it was useful to show the contents list. So the first section has some different chapters that are really useful for anyone to look at including the first chapter, which is all about how to make equality, diversity and inclusion fundamental to staff support working in any organisation, and also things related to organisational trauma, moral injury. And then in the practice, there are some lovely descriptions of interventions that involve compassion practices, including lots of links to free resources and practices that don't need to be run by psychologists. So that's the end of my presentation. I think we're going to have some questions in a bit. Thank you for listening.
Thank you, Harriet. You switched your camera on. Thank you so much. And I guess one of the reflections I had was I noticed in your introduction, you quoted a nurse leader, I think, saying we should stop calling it well-being. It's being, it's normal. It's not an optional extra. And I just wondered what your reflections were on whether the momentum for this work has continued post-pandemic. Where are we now compared with the focus that there was on staff support and well-being at the start of the pandemic?
Well, yeah, really good question. I think, I mean, I'm talking from a standpoint I know of being in a very large team in Guy's and St Thomas's of staff support psychologists. So there are 27 of us, but we do have a workforce of 25,000. So it's you know, it's not as high as it could be. However, our funding is charity funded, and it runs out you know, in a year's time. And I know of lots of other organisations where the funding has already run out, and so there have been services that were set up and then have been pulled already. I think the focus is now on very much on staff shortage and retention and meeting basic needs in the organisation, really. And it's understandable in some ways, I guess, that you've got to kind of address the needs of patients primarily, and staff can't be released to, if there is any staff support or wellbeing provision still left, they can't be as easily released. However, obviously it's chicken and egg, isn't it? And we know that you know, if you don't look after your staff, they're not going to be able to continue to work. They're certainly not going to work as many hours. We know that people aren't working so many bank shifts, or they're going home on time where they can, and so that all impacts on patient care ultimately. So yeah, unfortunately, I think we are in a different place. I think it still needs to be high on the agenda, and not in a kind of tick box way, though. It needs to be at all different levels of the organization, and organizations challenging higher up.
Yeah. Yes. So it's, yeah. And I guess it feels quite precarious in just listening to what you're saying, the fact that it's supported by the charity, will that continue? But also just that huge importance and connection with retaining staff and how supporting them becomes a really crucial part of that. I know you and I have talked a lot about the connections between supporting staff in managing conflict and also resources. And there was a really interesting thing that you said in your introduction, which was questioning healthcare opinion to the point of conflict is a modern day healthcare phenomenon that can impact on staff. And I just wondered, from your perspective in your role, what do you see as the relationship between helping staff to manage conflict and also supporting staff well-being?
It's really tricky. It's really tricky. I think one of the key things, and you know, I worked on a pre-brief yesterday which has got a conflict context, and I think it's trying to remind all parties of different perspectives. I think that's the key thing that we can do. And I think that I know that that's the kind of work that you as mediators, medical mediators, do when it comes to an extreme point. But I think it's in conversations with staff and teams, and sometimes with families. I know that psychologists and other professionals supporting families is just trying to open up that thinking, because I think both patients and families can become really kind of blinkered, obviously focused on threat to their loved one, but also I think staff can become blinkered because they're kind of overwhelmed, and people are really tired now across organizations. And so it's people's thresholds are much lower for what they can tolerate, I think.
Yeah.
So I think it's about opening up that understanding and trying to support that is one of the key things.
My last question before we open it up to questions from people listening was, how widespread and how consistent do you think the practice of debriefs is embedded across children's and women's services? I know what happens at the Evelina, but what happens, do you have a sense of how widespread that practice is? I still speak to staff and say, have you had a debrief when we've been talking about a conflict case? And they'll often say no, and it's been weeks since the event happened and they haven't been able to talk about it.
I think it's hit and miss. I think if you're talking about tertiary centres, they usually have psychologists, and that we're linked in nationally in paediatrics. And we've been working on psychological debriefs for quite some time. I think there is still in psychology and in sort of healthcare more broadly, that unfortunately there's still a lot of misinformation about debriefs, because at one point NICE guidance said that they needed to cease, but they were referring to a particular model called psychological debriefing, which the evidence that NICE drew on was from a Cochrane review, which has since been found to be quite problematic. I'll quickly say why, because it is a question that I am asked all the time. And for good reason, because I think people are frightened of causing more harm. So I think so psychological debriefing was actually an intervention that was originally developed to improve resilience, and then started to be used for trauma recovery for some reason. I don't know why. And an example of one of the flawed bits of evidence that the Cochrane review, which the NICE guidance was based on, used was where they ran groups for survivors of road traffic accidents. So individual survivors of road traffic accidents were brought together as a group, and then they used this psychological debriefing process. And surprise, surprise, they all re-triggered and re-traumatized each other, because they hadn't got a shared experience, but also they were using something which isn't designed to work with trauma. The kinds of debriefs that we run and that we would recommend, and there's a chapter in the book about it, and we, myself and other colleagues nationally have written about, is more about bringing people together and maximizing social connection and social support and their usual ways of coping. So it's not working on trauma, it's not about trauma processing, because you wouldn't do that, but it's a way of connecting people to their usual resources, which includes their internal resources and also their social supports. So it's more focused on that.
No. Lovely. I'm going to stop recording so that we can throw it open to questions from